I would like to call Mr. Sonu Singh, Director of Parthona Orthopedic and Super Speciality Hospital, to give a welcome speech. Please, sir.
And a very good evening to all. Pain is unavoidable, but suffering are optional. The team of Parthona Hospital, is committed to heal every pain. As the director of this young institution and the organizing head of this event, I would like to welcome all the guests to Parthona Burn Summit 2024. Parthona Hospital is not merely a name or brand, but a mission to provide a quality healthcare facility to the peoples of our region. We are here to provide affordable healthcare services to the peoples, and within the last 2 years, we had served our best to carve a name in the healthcare sector of Assam. I welcome Mr. Rahul Ami, Assistant High Commissioner of Bangladesh. I welcome Dr. Kavita Kalita, Head of the Department of Plastic and Reconstructive Surgery, GMCH, who is also our guest of honor for today. I welcome Dr. Seema Rekha Devi, former Head of the Department for Plastic and Reconstructive Surgery, GMCH, and also the key speaker of this wonderful event today. Thank you to all for being here today. I welcome Dr. Jeet Patwari sir, Healthcare Management Professional and Managing Partner, Pinnacle Healthcare Consultant. Dr. Arun Dekar sir, Head of the Department for Pain and Palliative Medicine, State Cancer Institute. Dr. Parag Niyok sir, Consultant, Manjovan Hair Transplant and Cosmetic Surgery Clinic, Apollo Excel Care Hospital. Dr. J.P. Sharma sir, Medical Superintendent, Marwari Hospital, Guwahati. Dr. Udayan Borwa sir, Medical Superintendent, Downtown Hospital. I welcome all the eminent and dignitaries from different hospitals and organizations. Hope this event will be an informative and memorable for us. Thank you.
We'll be having a short presentation by Dr. Dikshita Kakati. She is the CEO maxillary surgeon, and I will give the time to her. Please, ma'am.
A very good evening to one and all present here. I am Dr. Dikshita Kakati, oral and maxillofacial surgeon. So before starting my presentation, I just want to quote a beautiful quote which was given by Carl Jung. He said that medicine cures diseases, but only doctors can cure patients, which is very true. And I am very proud that we are the frontliner of health services. I welcome all here to the Burn Summit 2024, organized by Parthona Orthopedic and Super Speciality Hospital. So the hospital was established in the year 2021 on 1st of November. At that time it was named as Parthona Orthopedic Hospital, and it had 30 operational beds. Within next 6 months, we have introduced trauma center and accident and emergency unit, and soon we have changed to Parthona Orthopedic and Super Speciality Hospital. At the beginning we had 12 beds, 12 bedded ICU with only 1 OT, but due to rise in the cases, the number of OT was increased to 3. The vision of our hospital is to touch 1 billion lives, and our mission is to bring the healthcare of international standards within the reach of every individual. We are committed to the achievement and maintenance of excellence in education, research, and healthcare for the benefit to humanity. We have all the departments in our hospital with very efficient doctors who are well aware of all the services to be provided to take care of the patients. We have full-time physiotherapists and nutritionists, and we have round-the-clock critical care unit. We have 24/7 pharmacy services, laboratory services, radiology and imaging services, rehabilitation, blood bank and ambulance services. We have full-time anesthesiologists and experienced technicians who take care of all the critical patients who are present here. Recent add-ons to our hospital is the Department of Oral and Maxillofacial Surgery, Pain Clinic, Diabetic Clinic, and the Department of Physiology. In June 2023, the burn unit was introduced. The burn unit, we provide the best burn care service to the people of our region. Our hospital wants to bring the affordable quality health care to our people, and burn care is one of them. Our burn care unit is going to complete its first year soon, and we have successfully treated every burn case received by us, and in future our dedicated medical team will continue the same. Till now, approximately 12 patients have been successfully treated. Few pictures of our burn unit. In our burn unit, we treat the patient, we monitor and evaluate the patient, and finally, we rehabilitate the patient. Although our institution is very young, but we have achieved a lot of achievements, and I have enlisted a few of them. We have achieved the Assam Star Award in the year 2022, and we are the youngest organization to receive the NABH within 6 months. We have various MOU with prestigious institutions, and we are the parent hospital for St. Martha Institute of Nursing. Although we have a lot of IPD and OPD cases on a daily basis, we have international patients from various parts like Afghanistan, Bangladesh, Bhutan, Nepal, etc. Our hospital have a very prominent future aspects. We are ready to introduce the dialysis and nephrology unit, mother and child care including NICU and PICU, daily care, day care chemotherapy and IVF. Thank you for your present listening. And I assure all our listeners that our future sessions are going to be very much knowledgeable. Thank you.
Moving forward, we'll start with the first session. The topic for today is Awareness, Prevention and First Aid, Key to Success in Burn Scenario. For this topic, I would like to call Dr. Seema Rekha Devi. She is a former professor and head of Department for Plastic Surgery, GMCH. Past President of National Academy of Burns. Please, ma'am.
Parthona Hospital has started burn unit. As we all know, burn is a devastating injury. In a moment, the life is forever changed. You are no longer the same person once you are burned. And it is very important to know that burn can be prevented if you are aware of it. So, as we know, prevention is better than cure. And burn is one such injury which can be prevented if we are aware and we know how to deal with when we have a burn. So, burn scenario in the country, the darkest era, burn belonged to no specialty. You know, it was treated by one and everyone. And pathophysiology was not properly understood. And they were admitted in the surgical ward. We ourselves, we remember when we were doing general surgery, you know, the patients used to be kept in the end of the corridor where near the toilets. Nobody used to visit them. I remember one incident, you know, while I was doing my internship, and nobody used to, you know, dress them. Only the, maybe some interns or the, you know, even the sweepers and all that, you know, they just used to scrub and do, you know, whatever they like. And I was given the task of dressing a burn patient one day by one of my senior, you know, postgraduate student in surgery. And he asked me to do the burn dressing with a nurse assistant, and he was nicely, you know, smoking away in his room, reading a book. He was not there to supervise me. I, as an intern, I didn't know how to do it. But somehow, I finished. By the time, you know, the patient was asking for water all the time. The patient was dehydrated. I did not understand. Now I understand, you know, what was necessary for the patient. So, scenario was no better either in other parts of the world. Second World War changed burn treatment in some countries. I mean, in India, with large number of patients, the situation was still worse. We started quite long after the world started. So we fail to recognize skin is an organ. Skin is just not skin. It is an organ. As you can see from the picture, you know, it has epidermis, dermis, it has nerves, sensory nerve endings, sebaceous glands, and small capillaries. It's a full organ. And it must be divided, Very important to know that, from which time you would calculate the patient's, first 24 hours. It is not that if the patient is burnt at 5 a.m., comes to the hospital at 8 a.m. So usually people take 8 a.m. as a starting point. This is very wrong. So you must take 5 a.m. till next 5 a.m. next day is the first 24 hours. And you must divide it the first into 3 parts. So first 8 hours is half the total requirement of fluid must be infused in the first 8 hours, and rest half, 1/4 in the next 16 hours. So what is the endpoint of resuscitation? This is another very, very important point. When will you stop fluid? Giving fluid, IV fluid. This is very important. How to decide that this is enough, patient doesn't require any fluid. So you must assess the patient clinically. The patient will not look dehydrated. Patient will look, he has been hydrated, and his, your acceptance, and he'll be more verbal in talking to you. He will say he is feeling well. His urine output is, at least 30 to 50 ml per hour. So you must measure the fluid, which is also important. Then well, the patient has got enough of fluid now. So at the same time, there is another big question. Would you give anything orally to the patient? Many people, they say that, oh, patient is getting IV fluid. Why do you need to, give anything by mouth? He will vomit. If you don't give and start feeding at a later time, he will definitely vomit. But if you start early, he will not vomit. He vomits because later on, he develops paralytic ileus. There is nothing in the stomach. So you must start from the very beginning, some maybe in the liquid form. Slowly you can, increase the amount, and it must be calculated, this much is IV and this much we have given oral. So a proper input-output chart should be maintained. So there are some examples. So metabolism rate in 40 to 50% burn is 100 to 150% greater than basal. Weight loss, patient loses weight. Why? Because there is catabolism. Patient uses his own, body requirements from his own body. So within 2 to 6 weeks, there is so much of weight loss in burn patient. Even if you treat him very well, but then still he has weight loss. And less than 20% burn, they usually return to pre-burn level at 12 weeks. But percentage is more, then it may take more time. And then this dietary requirement will be very, very important. So this is some examples, first degree, second degree, third degree burns. What is not to be, not to be done in electrical burn? Don't panic, but everyone panics, isn't it? If you have a burn, you will definitely panic. And so, do not delay taking the patient to the hospital. Just remember that. So this is what happens, I have interviewed many burn patients with electrical burn injury. They are, not regular workers. They are not trained workers, because they have to be given low wage. So they are hired. They are not trained. They do not know, how devastating it can be, if they have electrical burn. So see, without any gadgets, he is going up to the electric pole, and he, works like that. We have approached the, ASCB also. They must not take, workers like this, and they must have regular trained workers with all the gadgets, safety gadgets, not like this. So even household current, you must put the main switch off, then only, repair work, whatever is to be done, you should do. So monitoring. So while you are doing all this, monitoring is very important. So fluid balance, input-output chart. Then hypotension is, remember, is a late finding in burn shock. You know, pulse rate is more sensitive monitor than arterial blood pressure. So look for his pulse, you know, at regular intervals to know whether the patient is in shock or not. Also, serial determination of hematocrit, serum electrolytes, osmolality, and calcium, glucose, serum albumin is a must. Dr. N.H. Antia in Mumbai, and the first most planned burn unit was started at Safdarjung Hospital with its own casualty, dressing stations, ward, operation theatre, etc. And the largest burn unit in the country, gradually the Safdarjung unit was the largest unit and became the gold standard and marked as the center of excellence. Of course, there are many more centers in the country now. So total burn care needs interdisciplinary team approach, improve acute burn care, prevent infection, improve nutrition, early surgical intervention, and we must help to eliminate contractures, psychological reassurance, which is very important, I'll come to it, and decrease length of stay, how we can reduce the length of stay, improve functional and cosmetic outcome, and reduce temporary and permanent disability. You know, sepsis is another very important factor that we must, take care of. So protocol hydrotherapy, every burn unit must have a hydrotherapy unit. We have developed a hydrotherapy unit in our burn unit at Medical College, and this is also one of the first burn unit under National Pilot Project for Burn Injuries. Before that, there was no such unit in medical colleges, and this became one of the first. It was started in 3 states in Assam and 2 other states, and we have to work very hard to get that burn unit. Thank you all for your patient hearing. I hope you have the presentation.
And for the eminent guest, I would like to call Dr. Udayan Borwa, Medical Superintendent of Downtown Hospital, Dr. J.P. Sharma, Director of Medical Services, Marwari Hospital. This is Dr. Gitatha Roy Meri to escort the Chief Guest, Guest of Honor, and eminent guest.
Now I request our chief guest, Mr. Ruhul Amit, Assistant High Commissioner of Bangladesh to Guwahati, to share a few words.
Good evening and namaskar to you all. It's a great pleasure to be here today in this important burn summit. Like India, we have seen a beautiful presentation from Madam. As a layman, I got to know a lot of things about burn injuries and what to do. Bangladesh also has a similar sort of problem like India. As a developing country, we have that sort of environment. Due to lack of information, we suffer from burn injuries. And more than actually 3,000 people dies from burn injuries in Bangladesh. So it's a high number. So this sort of awareness program can actually reduce the number of deaths and also injuries. If prevention could be ensured, most of the cases they could, many people could actually be saved from injuries and death. So in that case, I just say that the awareness program is very much necessary. Not only for this sort of setup, also maybe for education curriculum for primary or high school education. If this very basic information could be provided, we can save more lives from burn injuries in future. As for our cooperation and collaboration between Bangladesh and India, there is a lot of opportunities for medical tourism. Northeast, particularly Guwahati, has very good hospitals and medical facilities, and Bangladeshis are visiting India, different part actually. Not many patients are coming to Guwahati, but they are going to Kolkata, Chennai, Bangalore, Hyderabad, these places, and some are coming here. Like in the presentation we have seen, patients are coming to health sector in Assam. We can promote it to Bangladesh that Guwahati has very good medical facilities, and in many ways Bangladeshi patients would prefer Guwahati than other cities of India because of our cultural proximity, food habit, linguistic similarity, all these things, and that could help actually grow medical tourism in this part of India. Bangladesh has a huge population, 17 crore, one of the largest countries in the world in terms of population. So if you can get a chunk of medical patients from Bangladesh, it could be beneficial for the economy. For inviting me today, I have visited their hospital. They have wonderful facilities. My mother actually got treated there, and I believe the vision and mission they have, they can actually be one of the pioneers in many fields of health sector in Guwahati. With these few words, I would like to conclude. Thank you. Thank you very much.
And for preferring our hospital as a favorite destination for the patients of Bangladesh. Now I request our guest of honor, Dr. Kavita Kalita ma'am, to share a few of her valuable words.
Everyone, please don't panic. I'm not going to take much of your time. Only very few words. Dr. Seema Rekha madam has taught us not to panic when there is a burn. So please don't panic. So I would like to say, Baido has already said everything about burns. Very few things, one or two things. Skin is the largest organ in the body. People think heart, kidney, brain, these are very important things. But skin is equally important, rather it is more important. Because a person can survive with someone else's kidney when there is a kidney transplant. He can survive with someone else's heart also, someone else's liver, lung, etc. But no one can survive with someone else's skin. Dr. Seema Rekha Devi has already told us she has done homograph, means she has put the skin of the mother to the baby's body. Yes, we can do that and we do that, but it is not long lasting, it is not permanent. Like the kidney will be permanent in someone else's body also, heart is also going to be there for the whole life, but skin is not going to be there in someone else's body for a long time. It is only a temporary thing. It is like a temporary dressing. Lot of things are coming up, like pig skin, bovine skin, even fish skin. Those things, nothing is going to give a permanent cover to the body. So once the skin is lost, means it is lost. And we can recover that only with the patient's own body skin. So in a major burn, there is no skin. The patient is having no skin on his own. So how to cover that? So there are a lot of techniques, whatever it is. I want to say, whatever we do, how much time we take, it doesn't matter. But the life of a burn victim is never going to be like before. Never, never, never. Facial burn is never going to look like before again. Whatever we do. Whenever patient may be acceptable by the society, may be acceptable by the family, we can give the patient to some extent functional ability also. Hand is burned, we can make the patient do his household work or even sometimes skillful work like a musician. He will understand. He is there. So if the patient wants to play some music, that can also be done sometimes. But the face, the skin of the hand, the skin of the foot, whatever it is. Once the patient is in front of the mirror, he will have to look for his previous image, that is body image. So whatever we do, we are not being able to give the patient the original shape and size. So the only thing is whatever, how many doctors are there who are treating burns, new doctors are coming up to treat burns. Yes, that is also required because burn patients are increasing day by day in number. But at the same time, while treating the doctors, at the same time, we must do something to prevent burn injury from happening. If there is no burn, then nothing to regret. If there is burn, whatever we do, we have to regret. So awareness, teaching, everything is required to prevent burn injury. Thank you.
So I would like to request Dr. J.P. Sharma sir to share a few of his valuable words.
Pressure difference, positive pressure, everything included. So as Madam has rightly said, burns is not a one-person job. It is a multi-sectorial approach, and every individual, be it the nurse, be it the cleaner, be it the doctor, be it the physiotherapist, and the dietitian plays a very, very important role. But the most important role that is played in rehabilitation and management of a burn patient is the role of a psychologist. The psychologist plays a very, very important role. Please mark my words. I am telling you out of my own knowledge and practice. And in today's world, each one of us, every doctor, every medical practitioner is doing to his best of capability for the betterment of the patient. But please keep your documents proper. Tomorrow, once the burn victim goes out of the hospital, and when he or she slept a bill of 4 lakhs, 5 lakhs, 6 lakhs, 7 lakhs out of the pocket he or she has to pay, people are there who will instigate them to file a case against the hospital. So whatever you do, whatever verbally you have communicated, please make it a point, all those who are engaged in the practice, to keep everything documented and signed to prevent potential litigation and difficulty in your practice. So I wish Parthona, first I would like to congratulate you all for organizing this summit. It is very necessary. And what the first speaker, Seema Baidu, has already told, that creating awareness on burns, especially on prevention, because nothing is better than prevention. Prevention is better than cure. Thank you so much, and I wish all success to this summit. Thank you.
So we have another eminent guest, Dr. Jyotirmoy Sharma, Professor, Government Ayurvedic College, Department of ENT. So please come onto the stage. Skin donation and skin banking. I request Dr. Dipanjali Brahma. She is the in charge of burn unit in Parthona Hospital and also the head of plastic and reconstructive surgery of Parthona Hospital. And I request Dr. Plavita Saleh, senior pathologist from Downtown Hospital, to share the session.
I'm Dr. Dipanjali Brahmo, consultant plastic and reconstructive surgery and the president in charge of burn unit Parthona Hospitals. As we all know that burn is actually the burning topic at present. So like, as we all know, I'll cut it short. So since burn injury is one of the, in fact, the leading causes of disability adjusted life years, or DALIs you call it, lost in the middle and the low middle income countries. And in India, over 1 million people are moderately or severely burnt every year. And around 70% of burn victims are in the productive age group. And the burden is more among women, that is in the age groups of 15 to 49 years. And around 1 to 1.5 lakh get crippled and require multiple surgeries and prolonged rehabilitation. Socioeconomic status, the social situations, and the grave, the society in which we are now at present, the burn injuries and the care which the patients get, the treatment level, all these reflect, in fact, our society and in what level we have come around now. So, before going for talking about skin banking, I think I would say, let me clear certain things like what is skin banking actually? We always say skin banking, we go for, there are many, we always talk about organ donations, eye donation, liver donation, heart donation, but it's certain, actually it is a rarely talked topic, that it is skin banking, okay? So, and the first thing is that, as Madam had said, Seema Ma'am had said, that actually skin is one of the largest organ of our body. So, this can also be donated and harvested. The skin bank team will come to the donor's home and hospital or morgue, wherever the donor is kept, and we don't even need to shift the donor to the operating room, hospital or ambulance. Who performs the skin harvesting procedure? It is performed by the skin donation team consisting of the doctor, trained skin bank technician, 2 nurses and 1 attendant only. How is the skin harvested? It is done by a special instrument, that is a dermatome. And is the consent required for skin donation? Yes, you require a consent for the skin donation. And the doctor will explain the whole procedure and the next of the kin to the donor, and also a witness is required to sign the form, to sign the consent form. And so, like, from which part of the body skin is harvested? Skin is harvested from both the legs, both the thighs and the back. And is the entire thickness of the skin harvested? No, it is just the partial thickness of around 4.4 to 0.6 mm. Is there any disfigurement to the body? A very important question, because it deals with the emotional factors and many religious and cultural aspects. But here, so there is no disfigurement to the body even after the donation procedure. And the skin, the parts where we have harvested the skin, they are bandaged in a proper way. So again, what conditions render skin unfit for donation? That is the various conditions such as AIDS, hepatitis B, C, STDs, skin cancers, active skin disease and septicemia. And so what investigations? These things might also come. What investigations do you require? It is just the viral markers you need to test for. What about diabetes and hypertension? Even people with conditions such as diabetes and hypertension can donate. And so, again, a donor might say, how will my donation be used? Or how is my kin's donation going to be used? So, it will just be harvested, evaluated, processed, screened at the skin bank for the different disorders I had said, and then supplied to the burn surgeons for transplanting on burn patients. And it is preserved in glycerol solution between 4 to 8 degrees Celsius for a maximum period of 5 years. So again, the question comes, what is the expenditure of donating skin? So no payment is required for skin donation, and as it is selling and buying organs, which is skin is also an organ, so it is illegal. And the documents required by the skin bank team when they arrive is just a death certificate. So, is there any donor-recipient matching required for the skin transplant? No, there is no donor-recipient skin matching required. Once all the blood reports are negative, the donor's skin can be transplanted freely. So, is it compulsory to pledge or register ourselves with the skin bank if we wish to donate the skin? No, it's not compulsory. But if you have not registered, the skin donation will be carried out as soon as the call is received for the skin donation. And if you have registered, then you will get an ID card and a skin donation magnetic sticker, and that is enough. And in fact, even you can register yourself at www.skindonation.in. So this is just the procedures showing the consent, collection of blood samples, then cleaning of the body, then the harvesting procedure, and the dressing procedure which is done post-harvest, and the collection of the collected skin of the harvested skin. But in spite of saying all these things about skin banking, sadly this is the scenario in our country. There are around 19 skin banks in the country, with some states having even 6 to 7 skin banks, but there is no skin bank in our entire Northeast India. The first skin bank was set up in 1972 in Mumbai, but today is 2024, but there is no skin bank still in Northeast India. So we can understand this is the plight of our burn patients, how neglected they are till now. So this is what I said. Lacks of burn injuries occur every year in our country, in our states, in our regions. But there are no enough skin banks to meet the requirements, and lack of awareness about skin donation. And this needs actually to be changed. And in fact, if we have the facility of skin banks, many patients will be saved and their sufferings will be diminished. So again, concluding cutting short my presentation. So I'd like to say that skin banking is a lesser complicated process in our comparison to other organ donation, but it is a very neglected part of our healthcare system. And unlike kidney and a liver, which can be stored and which cannot be stored and need to be transplanted as soon as possible, a skin can be stored for 3 to 5 years. And this is the advantage, since it decreases mortality, increases survival rates and better healing outcomes. I think we the people of Northeast India, at least we should have the awareness that skin donation is not a very cumbersome procedure. It needs just a little bit of economy, but still we are lagging behind in that. Thank you.
Now I would like to request Mr. Sonu Singh, Director, Admin and HR for Parthona Hospital, to felicitate the speaker and the chairperson. Onto the stage, and I request Mr. P.D. Sharma, Director, Parthona Hospital, to felicitate the eminent guest. Dr. Jirmil Goswami and Dr. Hirajyoti Das, Medical Superintendent, Apollo International Hospital, to chair the session.
A very good evening to all the esteemed guests present here. I'm Dr. Jirmil Goswami, Head of Critical Care Unit, Parthona Hospital. Today I'm here to discuss a little bit about the role of critical care in burn patients. The key aspects are primary survey and secondary survey, calculation of total body surface area involved, ABCDE, fluid resuscitation, pain management, infection prevention, and potential complications. Burn patients presenting to the emergency department are admitted to critical care. Burn injury is characterized by hypometabolic response with physiologic, catabolic, and immune effects. Critical care plays a vital role in managing burn patients by addressing immediate life-threatening issues, maintaining organ function, preventing complications, and promoting wound healing. Classification of burns, ma'am has already discussed quite nicely about the classification, so I would not like to repeat it again. So I would like to start with the critical care part. First is a primary survey, stabilization of the patient. Airway maintenance with cervical spine stabilization, breathing and ventilation. Ventilation with high concentration till carbon monoxide toxicity is ruled out. Circulation and cardiac status protection with hemorrhage control. That is appropriate vascular access and fluid resuscitation. Disability, neurological deficit, and gross deformity assessment. E is exposure and environmental control. Secondary survey, it's for determination of mechanism of injury, evaluation of presence of inhalational injury, detailed assessment of the burn wound, and consideration of any possibility of abuse. Calculation of total body surface area of the burn, that is, there are two rules learned in the broader chart and rule of 9. I will not go into the details. So in acute stabilization and resuscitation, ABCDE, as I already said, airway, breathing, circulation, disability, neurologic deficit, gross deformity, exposure and environmental control. Airway management. Basically, patients with injury of the upper airway should be intubated as soon as possible, as any delay in intubation might cause total airway obstruction. Intubation can be performed by regular direct laryngoscopy, fiber optic bronchoscopy or intubating LMA. Rapid sequence intubation to be done in patients with facial burns when fasting status is unknown. Laryngoscopy may be impossible in patients with severe facial burns because of the rigidity of the cervical tissue. Neck incision might facilitate laryngoscopy in such cases. Small size EGT should be used as airway edema is almost always present. Modes of securing airway: endotracheal intubation, oral or nasal, needle cricothyroidotomy, surgical cricothyroidotomy or tracheostomy. What are the indications of intubation? All burn patients don't need intubation, but these are a few things which where intubation is absolutely required. It's airway obstruction, depressed level of consciousness, hypoxia, carbon monoxide poisoning, circumferential nasolabial burns, upper airway obstruction, chest wall restriction, subglottic chemical and thermal burns. Challenges in airway management. Severe face and neck burns may lead to difficult bag and mask ventilation. Direct heat and steam injury to the upper airway can lead to marked swelling of the face, tongue, epiglottis and glottic opening, resulting in airway obstruction and making laryngoscopy and intubation difficult and challenging. Inhalational injury leads to tracheobronchial injury and decreased mucociliary transport and impairs clearance of bacteria and mucosal debris. It also causes alveolar collapse, atelectasis and ventilation perfusion mismatch. Now in breathing, mechanical ventilation required, if required, the oxygen administration. Circumferential full thickness burns of the trunk and neck may impair ventilation and must be closely monitored. The motto is always intubate if in doubt. In circulation, proper intravenous access, proper fluid resuscitation is of utmost importance. Ringer's lactate is the fluid of choice. Now coming to disability, neurologic deficit and gross deformity. Begin the assessment by determining the patient's level of consciousness using the AVPU method. A for alert, we check for the alertness of the patient. V for we check where the patient responds to verbal stimuli. Then we give pain, and then U for unresponsiveness. GCS, Glasgow Coma Scale, is a more definitive tool to assess the consciousness level, but it is an easier method and can be done quickly. So, exposure and environmental control. Expose and completely undress the patient. Examine for major associated injuries. Maintain a warm environment. Remove all clothing, jewelry, body piercing, shoes and diapers. Prolonged application of cold compresses pose the risk of wound and body hypothermia. Wound hypothermia reduces the blood flow to the damaged area and may further deepen the injury. Maintaining the patient's core body temperature is a priority. Immediate irrigation is essential in all burns. Monitoring and investigations. Monitoring all standard ASA monitoring like pulse oximetry, ECG, heart rate. An arterial line for beat to beat blood pressure monitoring. Radial or femoral line can be used, and also because we need to do repeat ABGs, it is also useful for that. Then central venous catheter for drug, inotropes and fluid administration. And CVP measurement can also guide us in the fluid resuscitation. Laboratory investigations, routine blood tests. Initial lactate is a strong predictor of mortality. Electrolytes to be monitored regularly. Now coming to inhalational injury. It's a leading cause of death in burn patients.
Mortality is higher in the presence of inhalational injury. There are 3 types: heat injury to the airways, inhalation of toxic gases, chemical burn with deposition of carbon particles in lower airway. Inhalational injury to be suspected if there is presence of soot in the nostrils, sputum, mouth, singed facial and nasal hair, burns on face, tongue, pharynx, or if there is stridor or hoarseness. Diagnosis can be done by flexible bronchoscopy. We can see erythema, edema, mucosal ulcerations and carbonaceous deposits. ABG, initially normal and shows hypoxemia and metabolic acidosis. Now, carbon monoxide poisoning. When carboxyhemoglobin is more than 15% in blood, result of combustion of synthetic material, leading cause of death associated with fires. So how do we diagnose it? Mostly it's clinical. There is a typical cherry red appearance of the mucous membranes and nail beds. The patient will complain of headache, angina and tachypnea. Persistent metabolic acidosis will be seen. Treatment. The treatment is 100% oxygen. The carboxyhemoglobin level reduces by 50% if 100% oxygen is administered for 30 minutes. Oxygen administration is required for all major burn patients. For major mechanisms, electrical energy, it causes direct tissue damage, altering cell membrane potential, causing muscular tetany. Thermal energy, massive tissue destruction and coagulation necrosis. Mechanical injury, direct trauma resulting from falls or violent muscle contraction. There are 4 classes of electrical injury basically: 2 electrical burns, flash burns, flame burns and lightning injuries. See, this ma'am has already spoken nicely about it, so I'll just go through it once briefly. 2 electrical burns, there is an entry burn and exit can be seen. So flash burn, flame burn and lightning injuries. Now I'll come to the effects. Cardiovascular. Any arrhythmia can precipitate. We should be very careful because there is direct myocardial injury. High voltage or DC current can cause asystole. AC current can cause ventricular fibrillation. It is the most common cause of death. In respiratory, there is tetany of respiratory muscles, brainstem involvement, hypoxia and acidosis leading to cardiac arrest. Nervous system, there is disruption of sodium-potassium ATPase pump, breakdown of cell membranes. Vascular injury is intimal injury, coagulation, necrosis, aneurysms. Limbs, most severe injuries are seen at wrists and ankles. Renal involvement, there is acute tubular necrosis, acute renal failure and rhabdomyolysis. Other injuries, tympanic membrane perforation, vertigo, cataract, these things can happen. The management of electric burns, again it is A, B, C, D, E. I will not repeat it. ECG monitoring is very important to look for cardiac arrhythmias, as arrhythmias are very common. Fluid resuscitation as per the formula and to maintain adequate urine output. Now myoglobinuria, presence of pigmented urine. Myoglobin and hemoglobin pigments, rapid osmotic diuresis with initial alkalinization to minimize pigment deposition in renal tubules. Drugs used, mannitol is a drug of choice. Sodium bicarbonate is used. Ringer's lactate is given as bolus till urine is seen clear and free of pigments. Now coming to fluid resuscitation. Various formula are there. Most commonly used is the Parkland formula. So the amount of fluid required in the first 24 hours is 4 ml per kg body weight for adults and 3 ml per kg body weight per percent total body surface area burn. Half of this is to be given in the first 8 hours and the rest over 16 hours. Next 24 hours, colloids can be given as 20 to 60% of calculated plasma volume. No crystalloids in the next 24 hours. Other formulas are modified Parkland formula, Brook formula, modified Brook Evans formula. Increased fluids required if children less than 20 kg in case of inhalational injuries, delayed resuscitation, petrol and flame burns, and if other injuries are involved. Excessive fluid may cause, so we should be very careful, because excessive fluid may cause pulmonary edema, abdominal compartment syndrome, extremity compartment syndrome, and tissue edema. Supportive measures: all patients with burns of more than 10%, TT should be given. If prior immunization is absent or unclear, or if TT is taken more than 10 years back, 250 units of tetanus immunoglobulin should also be given. Hypothermia prevention is very, very important, as burn patients are very prone to hypothermia. And gastric decompression in all patients with major burns. Neck, oral and joint splints can prevent deformities. High voltage electric burns, hemoglobinuria, myoglobinuria, renal tubular obstruction. So now I'll come to measurement of adequate hydration. So we do the fluid resuscitation, but we also need to know whether the resuscitation that we are doing is adequate or not. So we'll look for the urine output. It's 0.5 to 1 ml per kg body weight per hour in adults and 1 ml per kg per hour in children. Catheterization to be done for early output monitoring. Heart rate of less than 110 beats per minute indicates adequate hydration. Heart rate more than 120 indicates hypovolemia. Narrow pulse pressure is an early indicator of shock and systolic BP. Monitoring for pulmonary edema. Large volumes of fluid resuscitation requires CVP monitoring. Now coming to pain management. It is the most challenging part for intensivists in burn patients, as it's a very painful condition. In pharmacological methods, opioids are the most commonly used drugs. So continuous intravenous infusion of opioids provides the mainstay of analgesia. Morphine still remains a drug of choice for patients without any threat to the airway. Fentanyl can also be used. Opioid transdermal patches are available. And nowadays, patient control analgesia is also there. So patient can himself or herself monitor how much painkillers they need. Non-opioids, acetaminophen should be used in all burn patients. NSAIDs, depending on the renal profile. Neuropathic pain, gabapentin, pregabalin should be added. Ketamine, low-dose ketamine can be used in adjunct to opioids. It can also be used for procedural sedation. Dexmedetomidine and clonidine can be used as adjuncts. Regional anesthesia, like giving regional blocks or putting catheters for continuous drug infusion. It provides improved pain relief, patient satisfaction and reduction of opioid use. Anxiolytics like benzodiazepines can also be used. Non-pharmacological, there comes the psychology part. It's cognitive behavioral therapy and hypnosis. Infection control in burn units is another challenge for the intensivists. Infection in burn patients is a leading cause of mortality and morbidity and a challenge for the burn team. Susceptibility to infection in burns is mainly due to the loss of skin, which is the first line of defense. Extended hospital stay, presence of invasive lines like Foley's or central venous lines, immunocompromised patients, thrombosis of subcutaneous blood vessels leading to avascular bed. Avascular bed, it becomes an excellent medium for microorganisms to grow. It prevents penetration of systemic antibiotics. The burn ward flora are mainly in the gram-positive MRSA, VRE, coagulase negative staph, then in gram-negative Pseudomonas, Klebsiella, Acinetobacter, and E. coli. Fungal mainly Candida, Rhizopus, Aspergillus, and Mucor. Modes of transmission: health personnel, lack of hand washing, visitors, inadequately decontaminated equipments and invasive devices, surrounding environment from other patients. Prevention of infection, general and specific. General is good clinical practices, prevention of specific ICU related infections. In specific, there is cultural surveillance, isolation, and antimicrobial policies. Good clinical practices include hand hygiene, barrier attire, that is the use of caps, gloves, gowns, masks, aseptic surgical techniques, biomedical waste management, sterilization and disinfection, presence of infection control professional, and cleanliness. Prevention of specific SU-related infections. Cannula-related sepsis, mostly due to the presence of central line, it's a very potent source of infection if proper precautions are not used. If patients on ventilator-associated pneumonia, and catheter-associated urinary tract infection is very common, and wound infection, definitely. Cannula-related sepsis, how can we prevent it? Placing the cannula or the central lines in non-burnt areas. Use of antimicrobial coated catheters, these are available nowadays. Catheter tip culture should be done if sepsis is suspected, and periodicity of change, it should be changed at regular intervals. VAP, increased incidence is seen in inhalational injuries. Prevention can be done by ventilator care, ET tube care, chest physiotherapy, which is very important, and innovative techniques of ventilation like high frequency percussive ventilation. Now, catheter-associated urinary tract infections, higher incidence is seen with perineal burns. So, catheter should be inserted only when indicated. It should be removed as soon as possible. Patient should be mobilized. Signs of infection, remove the catheter plus start antibiotics. Now, culture and surveillance. Early identification of colonizing organisms to monitor the effectiveness of current treatment, to guide empiric antimicrobial therapy, to quickly detect any cross-colonization. Isolation and barrier techniques. These are a separate cubicle can be used, curtains, laminar flow rooms, and private rooms. Specific precautions like bathing the patient early, enteral feeding, and avoiding common dressing rooms. Now, antimicrobial policies, every institution should have their own antimicrobial policy depending on what kind of infections are mostly prevalent in that particular institution. So avoid prophylactic antibiotics. Only role during perioperative period, during wound excision. Antibiotics only in case of signs of sepsis, depending on blood or wound culture. Now coming to complications, I will not go into details. There are acute or early complications, delayed complications, and late complications. Early complications include shock, which is very important in the first 24 hours, hypovolemic or neurogenic shock, laryngeal edema, renal failure, ARDS, hypothermia, upper GI ulceration, compartment syndrome, multi-organ dysfunction. In delayed complication, wound infection, septicemia, protein-losing enteropathy, DVT or pulmonary embolism. Late complications are scarring, disfigurement, contractures, hypertrophic scar, keloids, Marjolin ulcer. I will not go into the details. Thank you.
Now I request Mr. Ashraful Khandakar, Director Parthona Hospital, to felicitate the speaker and the chairperson.
Say that if the patient is having burn injury somewhere in the face area, or the patient is having some inhalational injury, so if the patient requires intubation, so it is suggested that instead of doing orally, in the first go itself the tracheostomy has to be done. So what's your input on that? Because after that, there will be laryngeal edema, there will be obstruction in the laryngeal airway. So it is suggested that instead of putting it through mouth, just directly go through the trachea. So what's the suggestion?
What I would like to say on it, according to the literature, the thing is that tracheostomy is an invasive procedure. Although intubation is also as a basic procedure only. But in tracheostomy, it should be considered in patients where ventilation is required for more than 7 days.
Palliative Medicine State Cancer Institute, Dr. Parag Niyok, Consultant, Hospital Superintendent, Marwari Hospital, and moderator Dr. Gitartha Roy Medi, Director of Medical Facilities, Parthona Hospital, and the organizing chairman. I please welcome the group of panelists to the stage.
At the outset, thanks to the organizers for inviting us here. With all the senior people here, it's difficult to delve into the details, and my teacher, Sima Madam is here, Senior Jayanta Madam Jayanta Sir is also here, Kavita Bhai is also here. But addressing the issues, establishing burn care itself is a big challenge because the level of care that is needed, which is very, very high. When we plan, we divide it into three categories, three segments. One is your infrastructure, the second is the manpower, and the third is the processes. Now, when it comes to infrastructure, when we look at the burn care units, we ideally design the burn units taking into consideration two set of standards. One is ISBI, International Society for Burn Injuries, and there is another organization called Interburns. They have also come with a lot of publications and literature, so we follow those protocols also. Now, when it comes, it starts right from the beginning, before a patient enters the emergency unit. Most of the hospitals, we directly take the patient directly to the ER, right, or to the triage. When actually, if you look at, there should be a decontamination zone. You never know, because as per our Indian culture, like Madam has already described, we put a lot of locally available things like cow dung or something, which are basically contaminants. So then after that comes the actual treatment for the burn. We need to have a specialized OT where it takes care of the relevant parameters like temperature, relative humidity, your air exchange, your airflow, your particle count, your positive pressure, and the entire system which is governed by the HVAC. Now, when it comes to the manpower, it is basically a multidisciplinary kind of care which is to be given, because it's not only the burn surgeon that is going to play the major role. You need to have medicine, surgery, burn units. One is there in Bombay, one is there in Indore, Soitram Hospital is there. So all these burn units are usually attached to a multi-specialty hospital, maybe in a secluded area in the same campus, but it is supported by a team of specialists from different departments.
Thank you so much. So as Dr. Dizit has said, that management of pain is a very important thing while maintaining a burn unit, a burn ward. So my next question goes to Dr. Arun Deka, that the management of pain in burn cases, I would like to request him to highlight on that because it's a very common complication.
Thank you very much, Dr. Gitartha, for inviting me in this auspicious occasion. I'd like to thank the organizers of Parthona Hospital for organizing such a summit, because it's very essential. Thank you very much. So regarding how to manage the pain and what are the complications of properly not managing the pain, I'd like to I'd like to say why pain should be managed in burn. It is saying that pain management in burn is not done properly. It is somehow undertreated, somehow it is neglected, somehow it is said that okay, you just bear on. That is the common thing we practice, we have seen practicing. But so since few years I am not doing any pain anesthesia or pain in burn, but whatever I have learned in my earlier experiences is to post-traumatic stress disorder. It is seen in the literature says post-traumatic stress disorder is more if pain is not treated properly, and it is less if pain is treated properly. There is a chances of post-traumatic stress disorder everywhere, but if pain is treated properly, the chances is less. Number one. Number two reason why pain should be treated properly is pain in burn. Actually, it is an acute pain. If you don't treat the acute pain properly, then it may lead to chronic pain. Acute pain itself is just a symptom of burn, whatever the type of burn may be. But if it goes to chronic pain, then it is itself a disease. So that is also one reason why pain should be treated. Third cause is, if you don't treat pain properly, then the healing will be delayed. So for proper healing also, proper healing of the injury, the pain should be treated properly. Now, what are the methods available to treat the pain? First of all, as Dr. Zilmil has said, that there may be some pharmacological management, there may be some non-pharmacological management. What is available here in our setup is, in pharmacological management, we can use either opioid drugs or non-opioid drugs, or some anxiolytics, some alpha-1 agonist, and some NMDA blockers. These are the classes of drugs we commonly use. So under non-steroidal anti-inflammatory drug or NSAID or paracetamol, we can use paracetamol. It is safe drug. As such, there is no complication using paracetamol. Blindly also you can use in most of the cases. And among the non-steroidal, again there are two types, COX-1 and COX-2. You can use COX-1 also and COX-2 also according to the need of the patient. You know all these things. And the most important category of drug is used is opioids. Among the opioids, we usually use weak opioids. There may be weak opioids, there may be strong opioids. Most commonly, most of the clinicians, they use the tramadol under weak opioids. Tramadol, they also use Fortin. It also comes under weak opioids. Fortin, Phenergan, they give sedation with Fortin and Phenergan. It is very essential. Just before treatment, you have to assess the pain. It may be mild, it may be moderate, it may be severe. So we have so many tools to measure the pain. We have to see the clinical, like vitals, blood pressure, take pulse, all these things, and whether there is lacrimation, whether it's just posture of the patient, and you can assess it through some scales like NRS scale, like VAS scale. These two scales are commonly used, NRS and VAS. If the scale is there, 0 to 10, you have to ask the patient where your pain lies. So according to you assess the pain, and accordingly, if it is severe, then you use the strong opioids. Under strong opioids, you can use morphine. Morphine infusion is very good to give a good pain relief. But morphine, for that, you need a opioid license. That is one problem. Otherwise, morphine infusion, you can give it IV or intrathecal also, no problem. But IV morphine is a very good drug to give a good pain relief. 1 milligram per hour if you can use, this is enough for the patient. Morphine is number one drug you can use. Number two drug is you can use fentanyl also for pain relief. Fentanyl is a bit costly. So to give continuous infusion, the cost factor will come. But morphine is such a cheap drug. Morphine is cheap drug, so you can use it. Then another drug very commonly used, it gives sedation also, analgesia also, anxiolysis also. That is your dexmedetomidine. This is a very excellent drug. It gives a good analgesia, good sedation, and good anxiolysis. Excellent drug. You can use it. The dose is 1 microgram per kg to be given in 10 minutes, then 0.2 to 0.7 milligram per kg per hour. It is a continuous infusion. Then another drug which is very essential, very important drug, where suppose total burn is there, so you cannot give IV saline, you cannot give cannula, then there is a drug patches is there. So two types of patches are there in common practice. That is, one is fentanyl patches, the other one is buprenorphine patches. buprenorphine patches come in 5, 10, 20 in the strand. 5 means 5 microgram per hour, 10 means 10 microgram per hour, 20 means 20 microgram per hour. And fentanyl patch come in 12.12, 25 and 50. It is commonly available. So if just put the patch, buprenorphine patch continue for 7 days and the fentanyl patch continue for 3 days continuously. It is a round the clock analgesia. It's a very non-invasive procedure, strong analgesia, excellent result. And also you can use some non-pharmacological, like already said by Dr. Zilmi, biofeedback, cognitive behavior also. Thank you.
Thank you so much, Dr. Arundeka. So along with pain, very common complication that we do see is this scar. That is also after the treatment. So management of scar is very important part in burn treatment. So we have the right person here, Dr. Parag Deok. So Dr. Parag, we would like to know, like during the treatment and also after the treatment. So how we will manage the scars? Burn scars.
Thank you very much, Dr. Gitartha. I think Seema Rekha madam has already elaborately told about the burns, the wounds and the possible complications what you can have, and the splintage and the pressure garments, everything. The problem in a burn is first to determine whether the burn will heal within 7 to 21 days or it will take longer, it requires a surgery. So first is the assessment of the wound, whether it's a 2nd degree deep burn or a 3rd degree burn, or it's a 1st degree or a 2nd degree superficial burn. That is mostly done clinically, but the accuracy rate is slightly lesser, 60 to 70%. But still that is what we rely on. And then in the superficial burns, it is mostly treated and the patients get well with a little bit of scarring. The scarring is always there, as Seema Rekha ma'am had told. But the other burns which require surgery, you have to really evaluate whether you want to do a surgery immediately, that is within 48 to 72 hours, or you plan to do the surgery later on when the eschar forms, you remove the eschar, the granulation tissue comes and you put in a skin graft. So I had the pleasure of, I had been a senior resident in Saudajang Hospital, one of the largest burns unit in the country. So we had a lot of burns cases. There were around 100 bedded burns hospital unit. We had around 20-25 bedded ICU. So we had done some tangential excisions there. But then the problem with that is, in a private setup, you need 2 teams basically. One is to excise the graft, excise the burn area, and the second team will be harvesting the skin graft. And at the same time, the procedure must go on. The blood loss must be very minimum. There's a lot of blood loss associated with that. And simultaneous work has to be done. But the advantage of that is that the morbidity goes down, the downtime goes down. And but you got to be careful there. You need to have a team, especially in the private setup. I've worked in a private setup for more than 20-25 years now. I've been treating burns patient on and off. Lately I have not been treating so much. But then you face that problem in a private setup where you don't get enough people to work alongside with. The other thing is you wait for the eschar to form, you do a debridement, wait for the granulation, and then you have to give it a cover. Even after a cover, there are a lot of problems like Seema ma'am already told, burn contracture, that's a major problem. Splintage is very much essential, pressure garment is very much essential, silicone gel sheet is essential. These are some of the things, and sometimes we do use a CO2 fractional laser also to reduce the scars. Scars are disfigurement, they are permanent, they stay for life. We have to try to reduce them in the first onset, make it less as much as possible. When they happen, we have to do a little bit of correction, but like my classmate and friend Dr. Kavita saying, so they always have a scar and it's permanent, so we have to help them And I think Parthona Hospital has made a very good attempt in creating a burns unit. I must congratulate them. This is a very major step in a private sector, because it takes a lot of willpower and a lot of manpower to man a burns unit, and it takes a lot of dedication. In a private sector especially, it takes a lot of dedication from a single unit to take care of the burn patients. Thank you.
Thank you, Dr. Parag. Now, another complication that we all know is the diabetes in burn patient. So, scars, it takes time to heal if the patient is diabetic. So, my next question is to Dr. Rupam Chaudhary. So, kindly highlight on management of diabetes during treatment of burn.
Thank you, Dr. Gitartha. As we all know, diabetes is the new pandemic of our era. You will be probably finding 50% of our patients in burn unit who has pre-existing type 2 or type 1 diabetes. So pertaining to that, it becomes a very big challenge if a diabetic patient whose glycemic control is not good, they presents with burns. Considering the acute complications that may happen, let us segregate it to acute complications, uncontrolled diabetes, and having burn injuries. The patient might land into DKA if it is type 1 diabetic patient, or HSS. DKA is very rare because type 1s, we know only 10% of diabetic patients are type 1. The 90% rest being type 2, hyperosmolar, hyperglycemic state is a major complication, acute state, where the patient will develop that condition they will develop very slowly. At presentation, they might have a sugar of 200, 300 because it's a stress condition, having any injury. Many times, the critical care physician will be using steroids for injuries, and burn itself is a stress environment where the body itself will release a lot of corticosteroids. So hyperglycemia is inhibited. In that cases, if the patient develops HSS, I will have to treat it very aggressively, and it becomes very difficult because the mortality of HSS is 10 to 20% as compared to DKA, which is 1 to 5%. So this is one acute complication. Second thing is the healing part and hospital-acquired infections. So we know type 2 diabetic patients are more prone to infections, and we have to step up the antibiotics because they will be getting a lot of antibiotics throughout their life because of recurrent UTIs or any other pneumonias or infections that occurs in type 2 diabetic patients. That is one thing, and they will be resistant to most of the antibiotics. We'll have to have very aggressive drugs. Sometimes even carbapenems are not enough. That is one challenge. Third thing is managing this type 2 diabetic patient who have hyperglycemic surge in burn unit. Intravenous IV insulin infusion is recommended pre, post, and if required for a longer duration of time. As the NICE sugar trial has given us this guideline of keeping the sugars in between 140 to 180. This is the acute complications. Infections we'll have to treat definitely very aggressively. Then segregation and zoning and isolating the patient is very important. Sugar control is important. Oral anti-diabetic drugs we usually avoid during the acute phase, but insulin as being an anabolic hormone really helps fighting the infections and also recovering from that phase. I would like to just, although it is not probably related directly to acute burn ward, but we cannot sum up this summit without talking about diabetic foot burn injuries. We all know that type 2 diabetes comes with neuropathy, that starts from our feet, and a lot of our patients, specifically in winters, they come with blisters and burn injuries, and that is leading to two foots are being amputated every minute worldwide. So this is a burning aspect of type 2 diabetic patient because the awareness is not there. So here also we'll have to stress upon, and Parthona Hospital will have to congratulate. You have not only set up a burn unit and also a diabetic food clinic. So This much is what concerning a type 2 diabetic patients, and prevention is what is required to prevent all those diabetic foot burn injuries by educating the patients and also giving them proper footwears and moisturizing their feet. Very small things, but you can prevent all those burn injuries by intervening very early in those patients. Thank you.
Thank you so much, Dr. Du. Very important. So the two type of manpower managements we know, that one is clinical and one is non-clinical. So my question goes to Dr. Seema Kaur ma'am. So regarding clinical manpower management, including the medical officers, experienced technicians, so that ma'am is following in her hospital.
Thank you, Gitartha. Namaste everyone. And I really thank ma'am for refreshing what burn care is all about, because just after MBBS I had started my journey as a JR in Safdarjung Hospital in the burns and plastic unit. So that was my first experience with burn when I had gone in the night duty, and it was a ICU of 20 bedded, and it was full of rooms. Like, we haven't seen that before, in college we haven't seen so much of burn patients together. We have seen just one or two in the surgical ward. When we were interns, we used to go. So that's the thing, that experience was very, very, exhaustive, and we really learned a lot. So when we say the clinical manpower, so when clinical manpower comes, it starts with the consultant level, and then it goes to the JMS level, so junior medical staff, the nursing staff, the technicians. So rest of them will definitely not come under clinical, but they are part of the treating team. So they are also very, very important. So what happens, first thing is that the staff must have empathy while treating a patient. That is most important. Because when it comes to burn, you first have to think of the preventive care first. First is prevention, then comes the curative part of it, then is rehab. So the most difficult part is the rehab part of it. So clinical part is somehow there are set protocols, and we follow those protocols. Every safety part that we have to see. The other things that the clinician sees is the main clinical part, which entirely they follow it through the SOPs. So that role of theirs is very important. And then the staff, they have to put in that empathy. Why I am saying, because following SOPs is easier. Somehow you know what to do, you know for infection control that you have to follow hand hygiene, that you have to follow sterility. All that part is there. But to prepare a patient, to stand during the rehab phase is very important. There the clinical personnel has a great role, because unless you infuse that during the treatment phase, it does not come in so easily, that acceptance doesn't come into the patient, because you have to see that, that positive frame of mind has to be kept alive for the patient for the entire course of treatment. So particularly, I would not like to talk about very technical roles of each and every staff. Actually, like that everyone knows. But then the part that follows is that the prevention is the main thing, that which the government of India also, I think they have put up a, NPP, MBI, this program is there that has been put up. This is a national program for prevention of burn injury. So in this, they have also stressed upon a category of people, that is the Anganwadi workers, the Asha Karmis, the ANMs, the midwiferys. So they also have a major role in the prevention part of it. Because if you see the data, every 4 minutes, I think we have a burn trauma case. In every 4 minutes, not even 5 minutes. So that's a huge number. For that, but substantially we haven't seen much being done at that level. even though the roles have been specified, but the outcome we haven't seen. So here, all of it needs to be stressed upon by, say, the government machinery also. And in case of the private organizations, definitely we follow a lot of protocol, lot of process. That's what gives us a good outcome for the patient. I wouldn't say much, but I'm sure they are going to do a good job, Parthona, because we also in our hospital, we do not have a burns unit. So we don't treat burn patients as such unless it is a first degree one. So definitely we will be needing your help only. Whenever we have a patient, we would definitely said and would expect that the patient has a good outcome. Thank you so much.
Thank you so much, ma'am, for your words of appreciation. The same question, I will go to Mr. Rohit Upadhyay to highlight on his experience.
Thank you, Dr. Gitartha, and I must congratulate Parthona team and the management, because see, to do something, the will of the management is very, very important. The will they have decided to have burn care unit in their hospital is a right direction, because in Guwahati very limited hospitals are treating the burn patients. Already Dr. Seema has said the empathy of the patient staffs are required while treating the patients in the burn care unit. See, non-clinical staffs, it's very, very difficult to motivate them. When they see the burn patients, they see the smells, the odors of the patients, the biomedical waste management team, as well as the housekeeping team. Your inventory management is very, very important. The resources which you need, whether it is the medicine or other consumables, you need to have proper right inventory. You cannot have more than the required inventory, because it will hamper your top line. I think none of we have talked about the finances, the billing part to the patient, because see, burn patients, they need multiple surgeries and prolonged treatment in the hospital. So communications to the patients, many of the times the clinical teams are very busy while treating the patients. So non-clinical teams, they need to be trained properly to communicate the patients and their families regarding the proper life. At the time of discharge or at the time of death, we face a lot of problems while settling the bills and other things, because ultimately in private setup, top line as well as bottom line, we need to take care of this. Ultimately, the staffs and the team need to be motivated from all the aspects. And the training, regular training to the staff, non-clinical staff as well as the clinical, already panelists has said, non-clinical staff, regular training to them is very, very important on all aspects. Communications, basic their own hygiene, and total management of this ward, including OT and other things, are very important. And at last, when the patient is dead, the management of the dead bodies are also very, very important. During COVID, we have seen in our state that COVID dead management was very good, body management. So that body, the team who is handling the dead bodies are also very important. We need to sensitize them the importance, because many of the times it happens once the patient died, the people who are handling this, they intend to neglect, but that's at the end journey should be very smooth. So are your things. Thank you.
Thank you so much, Rohit. Really a very good discussion, I feel. So all the panelists, they have highlighted all the important issues, all the important complications, all the important matters. Now I will go to the audience if they have any questions, any queries regarding this discussion.
It was a very nice discussions. Everyone has touched their own points. I just want to say one line. When you treat a burn patient or rather any patient, you must be very passionate about what you are doing. You should like what you are doing, and you should train your staff likewise. Thank you.
So over to Dr. Dikshita.
Now may I invite
Mr. Sonu Singh Ji, Director of Parthona Hospital, to felicitate our panelists.
We'd like to proceed towards our next session, that is physiotherapy and burn. I would like to request our physiotherapist, Dr. M.I. Mullah from Parthona Hospital.
Good evening, all in all present here. I, Dr. M. Islam Mullah, consultant physiotherapist of Parthona Orthopedic and Super Specialty Hospital. I would like to discuss the role of physiotherapy in burn patient. So, now coming to the PowerPoint presentation of role of physiotherapy in burn patient. So, today's topic content: what is burn, epidemiology, types of burn, goals of physiotherapist for burn patients, and management of physiotherapist. So, a burn is an injury to the skin or other organic tissue primarily caused by heat or due to radiation, electricity, friction or contact with other chemicals. Burns are a global health problem, accounting for an estimated 180,000 deaths annually. The majority of burn occurs low and middle income countries like Bhutan, Nepal, Bangladesh. In India, over 10 lakh people are affected moderately or severely every year. So, types of burn, depending on severity, the types of burn, the burn is divided into 4 categories. First one, first degree burn, second one, second degree burn, third degree burn, and fourth degree burn. First degree burn, also known as superficial burns. It is caused by sun exposure, hot liquids, etc. It involves only epidermis layer of skin. The skin appearance being red, moist, and no blister. Moderate to severe pain occurs in the superficial burn. The healing time of superficial burn is 3 to 7 days. Superficial partial or secondary to a degree burn, it caused by hot liquids with acid or alkali chemicals burns. It involves superficial papillary epidermis of skin. The skin appearance red, moist, blister, intake epidermal appendages, blanches to pressure. It caused by flame, electrical or high viscosity. It involves only deep layer of skin. The skin appearance dry, white and non-blanching. The minimal pain occurs in this burn. Healing time 3 to 6 weeks with scars. Immobilization of hand. Immobilization of hand. The most common deformity is claw hand deformity. This is the claw hand deformity. In the claw hand deformity, the MCP joint is extended. The PIP, that is proximal interphalangeal joint, and distal phalangeal joint is fully flexion, and wrist is flexion, and thumb is fully abducted. So like this, this is the claw hand deformity, also called intrinsic minus position. So if this deformity is treated, then we should use some, there are varieties of splinting used. Position of shape immobilization is the complete opposition of claw hand deformity. In claw hand deformity, MCP joint is fully extended. In the position of the shape immobilization, that is by the spleen, the MCP joint is 80 to 90 degree flexion in MCP joint, 20 to 30 degree in wrist extension, full extension of PIP and DIP joint, and palmar abduction. That is complete opposite of the claw hand deformity. Immobilization of the hand, thermoplastic plantar spleen, that is used as to prevent the claw hand deformity. Dynamic flexion hand spleen, that is used only extensor deformity, and dynamic extension hand deformity only used as flexor deformity. These are the spleen. So management of edema. Management of edema, elevation technique, carbon wrap, uses of carbon wrap, edema glove and dizzy sleep. There are varieties of wrap and technique used to manage or to decrease the edema. So elevation is the most effective technique to decrease the edema. So above heart level of any affected area or limb, either upper limb or lower limb, should be placed in should be elevated above heart level. So this is the diagram. The upper limb is placed above the heart level to decrease edema or any adhesion. Carbon wrap used to decrease the edema. Edema glove or dizzy sleep, specific for finger and hand management. Edema product. Rehabilitation of burn patient in subacute phase. Beyond the immobilization of the acute phase, beyond the immobilization of the beyond the immobilization of the beyond the acute phase of immobilization, beyond the acute stage of immobilization, inpatient and outpatient rehabilitation typically consists of variety of intervention. One is pressure garment therapy, silicone therapy, scar massage, range of motion exercise, mobilization technique, strengthening exercise, gait training, balance and fine motor training. So aim of physiotherapy in subacute phase: optimize the scar appearance, limit effect of scar contraction or prolong positioning on range of motion and function, address effect of prolonged bed rest. So common treatment technique in subacute phase: mobilization, under mobilization, gentle active range of motion exercise, passive range of motion exercise. And next one is scar management by the use of pressure garment therapy, silicone therapy and scar massage. So mobilization should be, burn patient should be mobilized as early as possible to avoid deconditioning, as possible prevent respiratory complication associated with prolonged bed rest. Gentle active range of motion exercise is a preferred treatment or initial treatment to give the patient by means of active muscle contraction to reduce edema. If any condition do not have move actively, then other technique should be applied, that is positioning changing to prevent the pressure sore or burn sores. Passive range of motion exercise in acute does not given or contraindicated, because if the give passive range of motion on patient, then burn area should be rupture or damage. This is the active and passive range of motion exercise. Stress physiotherapy. The stress physiotherapy also we should give, like percussion, vibration, shaking, for mobilize the secretion from the lungs, and also give the spirometry to improve the respiratory muscle strength and improve the breathing. Scar management. Scar is the most common complication in burn patient. Prevalence greater than 70% among those who suffer burn injury. Pressure garment therapy. What is the benefit of pressure garment therapy? It reduces scarring by hastening maceration. Number 2, pressure decreases blood flow. Number 3, local hypoxia of hypervascular scar. Number 4, reduction in collagen deposition. These are all benefit of pressure garment therapy. This is pressure garment therapy. All are available in the market. Scar massage technique, retrograde massage, effleurage technique of massage, static pressure, finger and thumb kneading, skin rolling, and friction. These are all the massage technique we should apply on scar. Guideline for massage during 3 stages of healing. In inflammatory phase, gentle massage to decrease edema and increase blood supply. Proliferative phase of healing, massage that applies gentle stress to the healing scar is recommended to ensure collagen is aligned correctly. Number 3, remodeling phase of healing. Massage should be progressed to include flowing stressing to minimize adhesion. This is proposed to aid scar tissue breakdown. Silicone therapy. How silicone therapy affect on scar? Hydration effect. Hydration can cause by the occlusion of underlying skin. It decreases the capillary activity and collagen production through inhibition of proliferation of fibroblasts. And number 2, increase in temperature. A raise in temperature increase collagenous activity, thus breakdown of scar. These are silicone therapy or silicone shape. Rehabilitation of burn patient in chronic patient. Healing process may continue for up to 2 years. Scar tissue remodels and mesures may require functional retraining, integration back into the community and activity. So we should get post-burn aerobic exercise. Exercise prescription frequency 3 to 5 times per week. Intensity 65 to 85% predicted heart rate maximum. Type treadmill training, jogging, running, and time 12 week each session 20 minutes. Exercise prescription, resistance training, frequency 3 times week, time 12 week, type like weight bearing, therapy exercise, etc. At the end, I would like to conclude that physiotherapy has a very important role in burn patient and should be administered to the beginning and continuing to the rehabilitation stage. Thank you.
Now I request Mr. Sonu Singh, Director, Parthona Hospital, to felicitate the speaker and the chairperson.
Though everybody has said right from all our esteemed panelists before that the physiotherapy plays a very good role, very important role in the rehabilitation of burn patient. So we have to be, right now if you see the current literature says there are a lot of other things have come up as a new things. So I would like to suggest you as a clinician, you should definitely have a, you should go through all those new things, new techniques, and so that you can apply on the patients. It will really help and make the rehabilitation time very fast compared to the conventional what we usually follow. So otherwise, so best of luck to Parthona for having this unit. Thank you so much.
He is in charge of the neurosurgery department in Parthona Hospital, to come up this stage, and Mr. Sonu Singh to felicitate him. Thank you so much, sir. Jyoti Bora to chair the session.
Very good evening to everyone, and thank you, Kiteshwar sir, for giving me such a good opportunity to say something about nutrition in recovery of burn patient. So today I am going to discuss about the importance of nutrition in recovery of burn patient. I am Indrani Datta, clinical dietitian cum nutritionist, Parthona Orthopedics and Super Specialty Hospital. So my first slide is regarding medical nutrition therapy goals for burn patient. So my previous speaker already told about all the types of burns and the metabolic stress and all these clinical related discussions already my previous speakers already said. So I am directly coming to my point, my little knowledge. I would like to explain the nutritional goals. First of all, to achieve the goal, we have to, as a dietitian, minimize the metabolic stress response by maintaining fluid and electrolyte balance. Point number 2, to meet the nutritional needs by providing adequate calories to prevent weight loss of greater than 10% of usual body weight, and providing adequate protein for positive nitrogen balance and maintenance and or depletion of circulating protein. And point number 3, providing vitamins and mineral supplementation to increase the fast recovery. My point number 3 is to prevent curling stress ulcer by providing antacids or continuous enteral feeding. So, commonly used formula is Puri formula to calculate the calorie for burn patient. Formula, it includes calorie needed per day is equal to 24 kilocalorie into per kg body ideal body weight plus 40 kilocalorie into percentage of total body surface area in case of maximum of 50% burn. So with this method we can calculate the calorie need for each and every burn patient. After that, preparing for or to achieve the nutritional goal, we have to face the various challenges like renal failure or low cardiac output or any other comorbidities present in burn patient. So renal failure is very common in burn patient. So for excessive fluid loss, hyperglycemia, stress response, vascular leakage or vascular damage. So in that case, in case of burn patient, we have to provide 1.5 to 2 gram per kg body weight, ideal body weight, we have to provide protein. But in case of renal failure patient, if creatinine level rises, so we have to maintain or we have to check the protein intake by calculating the protein intake from 0.6 gram to 0.8 gram up to 0.1 gram per day per kg ideal body weight. So in that case, we have to face challenges, or regularly we have to monitor the blood parameters of the patient or urine output. So it is or edema present in the patient body. So it is very challenging for us, and we have to calculate the fluid intake per day, and we have to check the 24 hours urine output, and after that the amount of 24 hours urine output plus 700 ml per day. By calculating this method for another next day, for another 24 hours, we have to give the fluid, including the IV fluid and oral intake also. So in that way, we have to calculate the fluid intake of renal failure patient in case of burn. So it is very challenging. After that, low cardiac output due to mitochondrial damage or increased oxidative stress. So again, we have to face some challenges, carbon dioxide production. We know that we have to provide high calorie, high protein and low fat diet for burn patient. But in that case, we have to minimize the calorie intake, we have to calculate the protein intake. That's all, it's a very challenging for us. And for that is why we have to monitor each and every day for that burn patient. And we always prefer as a dietitian for individualized diet plan for each and every burn patient, not means same diet chart for all the burn patient we cannot provide. So individualized diet plan is very important for each and every burn patient. After that, objective of nutritional therapy. The objective of nutritional therapy that we have to provide nutrition through enteral route within 6 to 18 hours of post-burn injury. On point number 2, maintain weight within 5% to 10% of pre-burn weight. Prevent signs and symptoms of micronutrient deficiency, which leads to delay in wound healing, and minimize the hyperglycemia in case of diabetic patient, or hypertriglyceridemia in case of stress response. So methods of nutrition administration through oral feeding or oral feed, otherwise that means for patient with 20% or less burn of total body surface area are able to meet their need with normal or regular high protein, high calorie diet. But they should be encouraged to consume calorically dense high protein diet involving family caregiver during meal times, help to promote good oral intake. Because they are mentally depressed, low appetite, always they suffer from this type of problem. So we have to counsel them to take food. So it is very challenging. Counseling is also very important for burn patient. So it is in normal cases like less than 20% burn patient, we have to counsel them very well, and also the caregiver and family members of the burn patient. And in case of major burn may require tube feeding or parenteral nutrition, that means enteral feeding and PPN and parenteral feeding. But in that case, enteral feeding is the preferred method of nutrition support therapy for burn patient. But parenteral nutrition may be necessary with early excision and grafting to avoid the frequent interruption of tube feeding required for anesthesia. It is very important, and sometimes we have to go through both the enteral and parenteral nutrition. So I already told the diet for burn victim, it is high biological value protein. We prefer animal source protein, which means rich in essential amino acids, and that means we have to provide 1.5 to 2 gram per kg ideal body weight. And high energy intake, that means calorie to be based on total body surface area. We have to calculate regarding the Curie method. And liberal portion of calories from carbohydrate, avoid overfeeding and give 6 to 7 meals per day, and high vitamin and mineral intake, that means vitamins like micronutrients like selenium, zinc, copper, vitamin A, vitamin C, etc. So these slides for sources of protein, and that means high biological value protein, and classification of protein like high biological value protein and low biological value protein. High biological value protein comes from meat, fish, egg, cheese, like etc. And low biological value protein comes from peas, beans, nuts, pasta, etc. So it is very challenging for us to provide adequate protein for veg patient, and in that case we have to provide them like supplements, like high protein supplement, or in case of diabetic patient, it is also we have to provide diabetic supplement to minimize the hyperglycemia, and it is means in that way we can manage the nutritional need of the patient. And this is a picture for high energy food carbohydrate. We prefer high fiber whole grain carbohydrate for burn patient. So these are the example of that carbohydrate sources. And again, that colorful fruits and vegetables always contain vitamins and minerals, which is very important for burn patient. That's all for today, but especially means again from my knowledge, I have to provide individualized diet plan according to the patient need, and we have to counsel the caregiver and family members that they should take balanced diet, and they must encourage the patient to take balanced diet after discharge up to 1 year to prevent any infection or malnutrition. Thank you.
Thank you, Indrani Madam, for giving us thanks with the N, B-U-R-N. So something we need to always focus the nutrition. And why we need the nutrition? To get rehydration, like B-U-R-N, rehydration and all. I think like Parthona Hospital has made a very good initiative for making such a burn summit. Maybe we can have, because nutrition is such a big topic. And when being a family physician and all, I always get patients ask to me what to eat, what not to eat. And so I think we should have sometimes a good workshop on nutrition only. And how to make the actually diet and all. Because people don't know what is balanced diet actually. What is macronutrient, at least the basic concept should be clear and all. Awareness is very, very necessary, and also for everything and all. So I think, Madam, thank you so much for giving, and also the calorie calculation and all. I think if you ask someone, we don't know the calculation also.
Yes, for each and every disease condition, we have different types of formulas to calculate the calorie need and protein need, all this.
Thank you, Madam.
My little knowledge, I can able to.
We need to share knowledge. Not everyone are here to learn only. So little means everything. Little करके तो हम लोग सब सीखते हैं. Thank you so much.
Thank you.
And I request Mr. Sonu Singh to join us on the stage. Also, Dr. Dikshita Kakoti and Dr. Nilam Thakuria, organizing head, joined by Mr. Ashraful Khandakar, also organizing head. Dr. Nilam Thakuria, organizing secretary, and Dr. Dikshita Kakoti, organizing member. And I request our organizing president, Dr. Dipanjali Brahma, to felicitate these members. Dr. Gazi Nasim Ahmed, Dr. Saptarishi Borua, Dr. Jiaul Haq, Dr. Arun and Dr. Kuntilraj Borbuhai and Dr. Shashikant to come onto the stage. Thank you so much, Dr. Nitin. Thank you, dear guest. Now, two special person we would like to invite to the stage is Mr. Amul Reddy, one of our sponsors, who has helped us to make this event successful today. Rajsekhar Chakrabarty. Thank you, both of you, for your support in organizing this event today. Thank you so much. Now I request for his dedicated service in making this event successful, Mr. Hidayananda Sharma onto the stage. Thanks a lot to all the eminent guests here, chief guest, guest of honor, all the speakers, all the chairpersons, all the panelists, dignitaries, and of course the staff of Parthona Hospital who has worked hard to make this day a successful one, a memorable one. Thank you so much. Let's join for the dinner now.